Assalamu alaikum. Our lecture today is about malabsorption syndromes. In this lecture, we're going to speak about three important subjects, starting with malabsorption, its causes, approach to reach the final diagnosis. Also, we're going to discuss celiac disease as a very important subject. We're going to learn its definition, clinical feature, how can diagnose a child to having celiac disease, and finally, what is the treatment. Also, we're going to speak about cystic fibrosis, the presentation of the disease, diagnostic criteria, and treatment. Malabsorption syndromes. Malabsorption syndromes are a collection of conditions that affect digestion and or absorption of nutrients. These diseases characterized by diarrhea, abdominal distension, failure to gain weight, and lastly, a fall in the growth charts. Classification of malabsorption syndromes. Malabsorption syndrome usually classified according to the predominant nutrient which is malabsorbed. So we divide the syndromes into 5 types. Patient with carbohydrate malabsorption, for example, lactose malabsorption, congenital or secondary lactase deficiency. Patient with fat malabsorption, the classic example of it is cystic fibrosis. Or patient to having amino acid malabsorption, like enterokinase deficiency. The patient could have mineral and vitamin malabsorption. A classic example is acrodermatitis enteropathica, which is a zinc malabsorption. Lastly, malabsorption could be drug-induced. For example, sulfasalazine, which will cause folic acid malabsorption, and phenytoin, it can cause calcium malabsorption. Clinical approach to a child with suspected malabsorption usually start with the history. We have to take a history regarding the onset of the symptom. Some of the conditions, like for example, congenital chloride diarrhea and microvillus inclusion disease, the watery diarrhea usually started since birth. While in gluten-sensitive enteropathy, the symptoms usually appear only after introduction of gluten into the diet. The nature of the diarrhea is also helpful in the differential diagnosis. For example, patients with carbohydrate malabsorption tend to pass explosive watery stool, while patients with exocrine pancreatic insufficiency they have pasty and yellow offensive stool. Patients with toddler's diarrhea they tend to pass green stool with undigested particles described as peas and carrots. The dietary history is very important. A common example is a child with chronic non-specific diarrhea, which is the toddler's diarrhea. The appetite of the patient also is very important. Patient with cystic fibrosis, they have very good appetite, while patient with celiac disease, they usually tend to have anorexia. After we took a detailed history, then we go on for physical examination. In a patient with suspected malabsorption, we have to search for, firstly, general sign of malnutrition, and then we go on for specific finding that can lead us for particular diagnosis. Patient who developing edema, this may result from protein-losing enteropathy. While if the patient have digital clubbing, we usually think of cystic fibrosis or celiac disease. The presence of perianal and circumoral rash can make a diagnosis of acrodermatitis enteropathica is highly suggestive. Carbohydrate malabsorption, usually the test for it starts with a simple screening test can be performed at the bedside, which is the clean test reagent for the presence of reducing substance. Then we can also check the stool pH by a pH paper. And also we can use a breath hydrogen test for suspected carbohydrate malabsorption. In case of fat malabsorption, we usually start with microscopic examination of the stool for the presence of fat. The result will be positive in the case of a presence of more than 6 to 8 droplets of fat per low-power field. Any positive or abnormal test should be confirmed by a more specific test, which is the 72-hour quantitative fecal fat test. The protein loss in the stool cannot be evaluated directly because bacterial protein account for a large proportion of the stool nitrogen. However, we can measure a spot stool alpha-1 antitrypsin level because this type of protein is resistant to digestion. Now we're going to speak about celiac disease. Celiac disease is an immune-mediated enteropathy. It is caused by permanent sensitivity to gluten in genetically susceptible individuals. Patients usually develop symptoms only after dietary exposure to the gluten. The gluten is usually found in the wheat, rye, oats. The activity of gluten usually resides in the gliadin fraction. Inflammatory response results in a certain histologic changes, which include total or partial villus atrophy, crypt hyperplasia. There will be increase in the intraepithelial lymphocyte. Also, there will be damage to the surface epithelial in the small bowel. Regarding the pathogenesis of celiac disease, this combination of genetic and environmental factor. For example, a monozygotic twin, the incidence in between them can reach up to 100%, while only 2 to 5% of the first-degree relative of a patient with celiac disease will develop symptomatic gluten-sensitive enteropathy at some times during their lives. Also, an HLA type DQ2 and DQ8, putting a patient at higher risk of developing symptomatic celiac disease. Some diseases and syndromes make the patient at higher risk of developing celiac disease. For example, type 1 diabetes mellitus, thyroiditis, selective IgA deficiency, and also syndromes like Down and Turner syndromes. Clinical manifestation of celiac disease, it's usually manifest during the first 2 years of life after introduction of gluten in the diet. Usually the patient presented with one or more of the following features. The patient may have failure to thrive, diarrhea, vomiting. They usually have anorexia. Sometimes or rarely they may have increasing appetite. The patient will have abdominal distension, have loose, bulky, full-smelling stool. On examination, can see feature of failure to thrive. That's to say, there is decrease in the growth parameters, there is muscle wasting, hypotonia, abdominal distension, and so on. Also, the patient may be presented with non-GIT manifestation. The most important is dermatitis herpetiformis, have dental anomaly, dental enamel hypoplasia, also bone like osteopenia, osteoporosis, short stature, and so on. In order to make a diagnosis of celiac disease, the patient may subject to serologic test, biopsy, and genetic testing. Regarding serological testing, we have antibody like anti-gliadin and anti-reticulin antibodies. They are often presented in a celiac disease. However, it's important to say that 10% of false positive rate for IgG anti-gliadin among healthy individuals. Another antibody is anti-endomysial and tissue glutaminase antibody. These are the most sensitive and specific screening tests for patients with celiac disease. However, both of these antibodies are of IgA class, So, false negative may be seen in patients with IgA deficiency. The best available serologic testing, screening test, is quantitative IgA level associated with transglutaminase and endomysial antibody assay. Nowadays, genetic tests play an important role in the diagnosis of celiac disease. Genetic testing for HLA, DQ2, and or DQ8 is playing an important role for the diagnosis of celiac disease. However, one third of a normal population will have one or more of other markers. So these markers will have strong negative predictive value but a very weak positive predictive value for diagnosis of celiac disease. With this limitation, the test can prove useful only to exclude celiac disease when genetic studies are negative in subject on a gluten-free diet or in a subject who's belonging to a high-risk groups. Although the diagnosis of celiac disease is strongly suggested by positive serologic test, confirmation of the diagnosis depends on the demonstration of mucosal changes on a small intestinal biopsy, which is performed endoscopically. This should be followed by resolution of symptom and catch-up growth upon gluten withdrawal. The biopsy finding in celiac disease usually will be total or subtotal villus atrophy, crypt hyperplasia, increased number of lymphocyte, intraepithelial lymphocyte, and lastly, there will be damage to the surface epithelial in the small intestine. These histopathological changes in the small bowel biopsy is regarded as specific, however, it is not pathognomonic. So, in order to making a celiac disease based on the biopsy, we have to prove that the patient have villus atrophy with hyperplasia of the crypt and abnormal surface epithelium while the patient is eating a diet that containing gluten. Subsequently, there have to be a full clinical remission after withdrawal of gluten from the diet. A control biopsy to verify the consequences of a gluten-free diet on the mucosal architecture is considered mandatory only in a patient with equivocal clinical response to the diet. Gluten challenge is not considered mandatory except in situation when there is a doubt about the initial diagnosis. For example, when an initial biopsy was not performed or when the biopsy specimen was inadequate or atypical of celiac disease. Treatment of celiac disease is dependent mainly on putting a patient off gluten restriction for a life. So all sources of wheat, rye, barley, and oat must be eliminated during the initial treatment. When the patient on gluten-free diet, there will be a clinical improvement that's usually evident within a week. Subsequently, the patient will have histological repair, which is usually complete after 3 months to 1 year. Serological marker like tissue transglutaminase titer, it may be decreased on gluten-free diet, however, it usually do not disappear from the serum. Sometimes the patient will require treatment with corticosteroid. It is needed only in a very ill patient when there is a sinus symptom of what is called a celiac crisis. This is occur when the patient have attack of profound malnutrition, diarrhea, edema, abdominal distension, and hypokalemia. Prognosis of celiac disease, as a rule of thumb, clinical and histological recovery is usually occur. The most serious consequences of celiac disease, of long-standing celiac disease, is development of malignant lymphoma of the small bowel. However, the risk of development of this complication is usually decreased with restriction of the gluten in the diet. Cystic fibrosis is a life-shortening autosomal recessive disorder. Although it is predominantly seen in people of European descent, it has been reported in all races and ethnicity. The gene responsible for cystic fibrosis is located at the long arm of chromosome 7. It is encoded for cystic fibrosis transmembrane conductance regulator. It is a chloride channel that's located on the apical surface of epithelial cell. These are important for the proper movement of salt and water across the cell membrane and maintaining appropriate composition of various secretion. This is especially important at the airways, liver, and at pancreas. Classic hallmark of a patient with cystic fibrosis is development of chronic progressive pulmonary diseases. Patient will have pancreatic insufficiency and high sweat electrolyte concentration. Patient with cystic fibrosis will have a chronic respiratory infection. Patients usually have endobronchial colonization with bacteria, especially Staph aureus and Pseudomonas aeruginosa. Chronic bronchial infection, it will result in a persistent or recurrent productive cough, especially in an older children. Chronic airway infection, it will lead to airway obstruction, bronchiectasis, and eventually it will lead to pulmonary insufficiency and premature death. The median age of survival is currently about 40 years. Digital clubbing is common in patients with cystic fibrosis, even in those without significant lung disease. The patient also will have a chronic sinusitis and nasal polyposis. In addition to that, pulmonary infection with organisms such as Pseudomonas aeruginosa and some strain of Burkholderia cebacia are difficult to treat, and it may be associated with accelerated clinical deterioration. About 90% of patients with cystic fibrosis will born with exocrine pancreatic insufficiency. The inspisation of the mucus with subsequent destruction of the pancreatic duct, which result in the inability to excrete pancreatic enzyme into the intestine, which will lead to malabsorption of the protein, sugar, and especially fat. Fat malabsorption will manifest clinically as steatorrhea, which is a large, full-smelling stool. The patient will have deficiency of fat-soluble vitamin, which is A, D, E, K, and also will have failure to thrive. Protein malabsorption can present early in infancy as manifestation of hypoproteinemia with peripheral edema. About 10% of the patients with cystic fibrosis will be born with intestinal obstruction that is caused by inspissated meconium. They will have what is called meconium ileus. In older patients, the intestinal obstruction may be result from thick inspissated mucus in the intestinal lumen. They will have a distal intestinal obstruction syndrome. In adolescent or adult patients, progressive pancreatic damage can lead to enough islet cell destruction that will cause an insulin deficiency. Initially, it will result in glucose intolerance, but with the time, true diabetes that require insulin therapy may develop. It is called cystic fibrosis related diabetes. The failure of a sweat duct to conserve sodium and chloride, it will lead to hyponatremia, hypochloremic metabolic alkalosis, especially in infancy. Regarding reproductive duct, inspisation of the mucus will result in a reproductive dysfunction in both genders. In male, congenital absence of vas deferens and azoospermia are nearly universal. In a female, secondary amenorrhea is often present as a result of a chronic illness and reduced body weight. So fertility can be diminished by malnutrition, abnormal cervical mucus. However, women with cystic fibrosis can conceive. Diagnostic criteria for cystic fibrosis include presence of typical clinical feature, respiratory, GIT, or genitourinary, or a history of cystic fibrosis in a sibling, or a positive newborn screening test. One of these should be present with and evidence of lab evidence for cystic fibrosis transmembrane regulator dysfunction, which is occur in the presence of either a too elevated sweat chloride concentration that's obtained on separate days, or if we identify at least two cystic fibrosis mutations, or in the presence of an abnormal nasal potential difference measurement. Sweat testing is regarded as the standard approach for the diagnosis of cystic fibrosis. Although the test may be difficult to perform during the first 2 weeks of life of the neonate because of a low sweat rate, however, it is recommended at any time after the first 2 days of life. Positive results should be confirmed, and for a negative result, the test should be repeated if suspicion of the diagnosis remains. A positive result obtained from sweat test on 2 or more occasions, usually a positive test when the sweat chloride is more than 60 milliequivalent per liter, while borderline it is between 40 to 60. Negative test is regarded when there is less than 40 milliequivalent per liter of chloride in the sweat. Sweat chloride tests have false positive and false negative results. An example of patient who have false positive result is seen in patients with untreated adrenal insufficiency, those who have ectodermal dysplasia or endocrine abnormality like hereditary nephrogenic diabetes insipidus, hypothyroidism, hypoparathyroidism, also patients who have metabolic disorder like mucopolysaccharidosis, while false negative tests are usually seen in patients who have hypoproteinemic edema. Regarding prognosis of a patient with cystic fibrosis remains a life-limiting disorder. The median age of survival is 37 years. Male survival is somewhat better for reasons that's not readily apparent. Infants with severe lung disease sometimes die during infancy. However, most children survive this difficult period and they are gone to adolescence and adulthood. The slow progression of the lung disease eventually will reach to a disabling proportion. Children, those who rise in a poor socioeconomic status, usually have a poorer prognosis. Most children will attend school and they eventually will graduate from college, and usually they found a satisfactory employment. With increasing lifespan of the patient with cystic fibrosis, they tend to have some sort of psychosocial problems.